quick intro and the opening of the session, sir. Tech team, please start it.
Recording in progress.
One minute, please. 1 minute.
Yeah. Meanwhile, Dr. Balbi Singh, your video is being paused.
I think Dr. Balbir is going to join back again. The internet is snapped.
Yeah, I think it's.
Yes, I will.
Yeah, are we live?
We are live. You can start. Please start.
Thank you. Good evening, doctors. I, Saurabh Agrawal, Vice President, Sales and Marketing for Lupin. Welcome you all for today's ESC at Glance program. I hope you and your loved ones are safe and are continuing to take necessary precautions to fight the pandemic of COVID-19. As a medical fraternity, I would like to thank each one of you for treating and taking care of your patients and supporting the country in the fight against this pandemic. With number of active cases almost plateauing or reducing, we hope the situation is far better in control now, and in the coming months, it should further improve. At Lupin, we continue to extend our support to medical fraternity and also the patients at large by providing various support in terms of safety gears, ensuring availability of medicines continuously, and ensuring that every corner of the country is served well in this fight against COVID-19 pandemic. Coming to today's evening, we have an interesting agenda online today, and Lupin has always been a catalyst in terms of fostering scientific knowledge and sharing the medical advances by partnering with various global universities, societies, and bodies. Today, we have pleasure of sharing with you the highlights of recently conducted European Society of Cardiology's Annual Congress 2021. Along with path-breaking trials, latest guidelines, and relevant topics, I'm sure there will be a lot of interesting discussions which will be of clinical relevance to various doctors which are attending this program with us today evening. It's my pleasure to welcome our international faculty, Dr. John McMurray and Professor Peter Toth. Welcome to both of you, sir. We can be sure that today's evening will be ably shared by these two leading KOLs from the global bodies. And also, we have pleasure of having leading Indian KOLs, Dr. Balbir Singh and Dr. Sunil Sathe. Lupin has always been at the forefront in terms of conducting such programs which are best in science, which provide latest information, which are something which is contemporary to all the clinicians which are attending the programs. In today's program, I have been specially requested by both the Indian KOLs, Dr. Sunil Sathe and Dr. Balbir Singh, to keep the introductions short, and hence I would not take much time. I would request my team to put up the slide for introduction of both Dr. Balbir Singh and Dr. Sathe. Goes without saying, both doctors are the thought leaders in India. They have been pioneering a lot of work in terms of cardiology and guiding numerous students and clinicians and physicians across the country in terms of how to manage various cardiovascular disease and disorders. Can you go to the slide for Dr. Balbir Singh? Yeah. Dr. Balbir Singh is the chairman for cardiac sciences at Max Super Speciality Hospitals in the PAN Max group, which is Saket, Patparganj, and Delhi NCR. Of course, he is an eminent cardiologist with a lot of exposure on electrophysiology and other streams of cardiology. I'm keeping it short, Dr. Balbir, as being requested by Dr. Sathe. I know you don't need an introduction. I'm sure doctors all across the country know both of you very well. Coming to Dr. Sunil Sathe, Dr. Sunil Sathe is a senior intervention cardiologist from Pune. He is working with Ruby Hall Clinic in Pune, has a own cardiac center and counseling center, and has been pioneering in various work and supporting institutions like Ruby Hall, Wadia, Sahyadri, and Pune Hospital at Pune City. Dr. Sathe, as per my commitment, I am keeping it short. And with that, I would hand over to Dr. Sathe to take the proceedings for the evening today. Over to you, sir.
Thank you, Saurabh, for a short introduction. I think today evening we have a feast of academics because we have very two prominent and eminent professors of cardiology and medicine with us to share their experiences and tell us the gist of what was new at the ESC this year. We have with us Dr. John McMurray and Dr. Peter Toth. I think both very well known to all of us, and their huge experience in the field of cardiology and medicine is what we really want, so that we can widen our knowledge. And they'll tell us today what was new in the ESC 2021. So I would now request my friend and colleague, Dr. Balbir Singh, to start the proceedings of the first half. He will be introducing Dr. McMurray and take over the discussion part in the first half. Dr. Balbir Singh, please.
Thank you, Dr. Sathe, and it's a great privilege to introduce Dr. John McMurray. Actually, he's known to all of us, and his papers we read every day. So his contribution to heart failure have been just enormous. Apart from the several awards and kind of papers we have got, I think he has contributed to heart failure in a very big. So from RD, he moved on to SGLT2 inhibitors and fabulous trials. And we saw the DAPA-HF trial. And we've seen so many papers which we've read in New England Journal of Medicine. It's fabulous. And his attachment to India, we miss him because of the COVID, because I remember having had him here in two big meetings. And it was such a pleasure to have John McMurray. And I hope next year we'll bring him back to India. And we look forward to him contributing again to our physician forum with his fantastic lectures. So it's a great honor and privilege to have him here on this lecture. And I would love to have John McMurray present his slides.
Thank you very much for the kind introduction. Thank you for inviting me back again. And I really wish I could go to India, but sadly not at the moment. So if I share my screen, hopefully that's going to work. And I put it into full screen. Okay, so I'm going to try and give you an update on heart failure from the ESC. And I was asked to talk about two things. One was the new guidelines, and the second was any key trials that presented at the Congress. So I'll start with the guidelines. These are my disclosures. So this was a very interesting guideline. This is about my 5th time, I think, doing the ESC guidelines. And I realized how much more complicated writing a guideline has become. This is a very large guideline. You can see it's 128 pages long. And really, we had to break into subspecialty teams to work on different parts of the guideline. Really, the management of heart failure and its comorbidities has become so complex that really nobody's an expert anymore in everything. And it was also an interesting guideline because for the first time, in my experience at least, this guideline required anonymous voting for every recommendation, and 75% of people had to agree with any recommendation before it was accepted. So a somewhat more complicated guideline process than previously. There is an official slide set coming out. I'm not sure if it's out yet. The version I have has 118 slides, so clearly I can't show all of those. I'm going to have to be very selective in what I cover. So at the very start of the guideline, you can see this sort of table that talks about some new concepts in the guidelines, and I'll go through the ones of these I think are important and really do change things. So before I go through those, because we will talk about recommendations, I just want to remind you about the way that the ESC classifies recommendations. So there's a strength of recommendation, which is the class, going from class 1, which is a firm you should do it, it's recommended, it's indicated, all the way through to class 3, which is a firm it's not recommended. Class 2 is where there's maybe a less firm recommendation. Class 2A, you should consider it. Class 2B may be considered, and that's really a much weaker recommendation. So remember, those classes of recommendation. Remember in particular that color coding, because it will come up throughout the guideline, from green being the strongest recommendation through yellow and orange. And then each recommendation not only has a class, but has a level of evidence of which that class of recommendation is based upon. These remain, I have to say, a bit controversial. Level A evidence being multiple randomized trials or a meta-analysis. There's a lot of disputes about whether a meta-analysis really should be given level A evidence. Level B evidence is data derived from a single large randomized trial or large non-randomized studies. There is a lot of debate and controversy about giving a level B based on non-randomized, in other words, observational data sets. And then level C is simply consensus, really. It's people's opinion. So let's start with the new concepts with that background about strength of evidence and class of recommendation. And the very first thing mentioned in this table of new concepts is the change in description of a intermediate heart failure phenotype that was first described in the 2016 guideline. And in 2016, patients in the ejection fraction range 41 to 49% were said to have heart failure with mid-range ejection fraction, and that's now been renamed heart failure with mildly reduced ejection fraction. Now, why did that happen? Why was this terminology, this description changed from mid-range to mildly reduced? And that it's really because of two things. One is, with more and more data sets being examined, it's become clear that patients with heart failure and mildly reduced ejection fraction really resemble patients with heart failure and a clearly reduced ejection fraction much more than they do patients with heart failure and a more normal ejection fraction. So patients in the mildly reduced ejection fraction range, like patients with a clearly reduced ejection fraction, tend to be predominantly men, tend to have more coronary heart disease or an ischemic etiology, and so on. So these patients are more like those with a clearly reduced ejection fraction. And as we'll see in a few minutes, they also, we believe, respond to the treatments that are effective in patients with an ejection fraction below 40%. So in terms of clinical characteristics, they're more like HFrEF, and in terms of therapeutic response, they seem to be more like HFrEF, hence why they have been renamed patients with mildly reduced ejection fraction. The other two things I think the guideline highlight as major changes are in the simplified treatment algorithm for HFrEF. And here is that algorithm. So green, remember, is class 1 recommendation. Yellow is class 2A. So you can see here that this simplified algorithm now recommends 5 types of drug therapy. So ACE inhibitors or RNase, beta blockers, MRAs, and of course the new thing is an SGLT2 inhibitor. As you'll see in a moment, these are recommended to reduce mortality, loop diuretics to improve symptoms and relieve congestion. And then for subsets of these patients, once they're optimally medically treated, it may be appropriate then to use devices, ICD, CRT, and then the guideline recommends after that, if the patient remains symptomatic, there are additional therapies that can be used. And those additional therapies are described in another, as it's called an algorithm, not really sure it is an algorithm, but this is it. And this is really targeting, as the guideline describes, therapies according to patient phenotype. By that, it simply means certain clinical characteristics. So as you can see here, if the patient's got, it is in sinus rhythm and has a wide QRS on the ECG with a left bundle branch block configuration, then CRT is recommended, ICD is recommended in patients with an ischemic etiology with persistently low ejection fraction. I won't read through all of these, but you can see also various interventions for comorbidities, and even now we've got very strong recommendations for valve interventions in patients with heart failure. So this is just the top half of that algorithm blown up, and just to emphasize at the top here, you can see, as we've talked before in presentations in India, about the 4 new pillars of therapy, the 4 core life-saving treatments, an ACE inhibitor, RNA beta blocker, MRA, and SGLT2 inhibitor. This is the bottom of the algorithm, so you can see it more clearly. And again, there is a broad recommendation, strong recommendation, class 1, because you see it's in green, for exercise rehabilitation and for multi-professional disease management programs. So in a lot of Northern Europe, we manage our patients very closely with specially trained nurses and pharmacists who assist us, for example, with drug titration and patient monitoring. So these are the class 1 recommendations. You can see, as I mentioned, there are 5 of these. 4 have got a class 1 level A recommendation. And of course, the new one here is SGLT2 inhibitors, dapagliflozin or empagliflozin, getting a class 1 level A, so the highest, the strongest recommendation that you could get, leapfrogging actually sacubitril valsartan, because although there is a lot of discussion, and I mean a lot of discussion and a lot of voting about this, in the end, the committee did not feel that they could elevate sacubitril valsartan to level A evidence. I realize that's probably contentious, but nevertheless, it's a class 1 recommendation. SGLT2 inhibitors, of course, got a level A recommendation because there are 2 trials. If you remember, level A was a meta-analysis, or 2 trials. We have 2 trials in HFrEF, and indeed we have a meta-analysis. So by all of those criteria, SGLT2 inhibitors deserved a level A of evidence. And these are the 2 trials side by side, same endpoint shown here in this figure, same y-axis scale. You can see this entirely consistent benefit. We've talked about this many times before. And in the meta-analysis, you can see that this treatment is effective in patients with and without type 2 diabetes, and SGLT2 inhibitors are also effective when added to an ARNI, when added to sacubitril valsartan, as you can see here in this meta-analysis. So no question that this is a valuable additional therapy that adds to the best available alternative treatment that we can give our patients with heart failure and reduced ejection fraction. Again, the guidelines go into all of this in more detail. I'm not, but I think you all know that these drugs also improve symptoms and, in addition, slow the rate of decline in kidney function over time. So obviously very important. And that's probably the biggest single new thing in these guidelines. Here are the other pharmacological treatments for heart failure and reduced ejection fraction. These are what I would call the old favorites. There's no change in the level of, in the class of recommendation, and obviously no change in the level of evidence. And that's also true for hydralazine and isosorbide dinitrate combination therapy, and of course, digoxin. What is new in the pharmacological therapy recommendation is vericiguat, which is a soluble guanylate cyclase stimulator. And this gets a 2B recommendation. So level B, because there's only one trial, that's the Victoria trial, which I'll briefly review in a moment. And 2B, which is may be considered, which is not a strong recommendation. And again, I'll show you why that is in a moment, although I hasten to say this drug, as far as I know, is not approved yet in any jurisdiction except the United States. So as I mentioned, the drug stimulates this intracellular enzyme, soluble guanylate cyclase, increases intracellular cyclic GMP, was studied in this single large randomized trial called the Victoria trial, which enrolled pretty sick patients. They'd all recently been in hospital, or indeed some were even in hospital. And as well as recently being in hospital, they had to have a substantially elevated NT-proBNP level, more than 1,000 picograms per mil or more. That's a lot more than in the SGLT2 inhibitor trials. Overall, as you can see here, the trial was positive, but the treatment effect size, at least in relative terms, was quite small. Hazard ratio of 0.9 is a relative risk reduction of 10%. These were very sick patients. You can see that 50-odd% of them within about 2.5 years had experienced the primary endpoint. So the absolute risk reduction was relatively large, but the benefit was really only for heart failure hospitalization. So we've got a rather modest benefit. It's really only for heart failure hospitalization, and hence the somewhat weak class of recommendation, the class 2B recommendation, as I mentioned, approved earlier this year in the US. And I still personally have trouble knowing where this drug is going to fit in the guideline, in the treatment algorithm. It's certainly not going to come high up. Here you see some follow-up publications, and we were, I suppose, a little bit troubled by these, because you can see here that the treatment seems to work best in patients with a lower natriuretic peptide level, seems to work best when patients are more remote from their heart failure hospitalization. This is a continuous hazard ratio. You can see here it is most clearly below 1 when patients are considerably beyond their admission to hospital. And then more recently, we saw some data published from the trial showing that vericiguat leads to a small but significant increase in creatinine. So again, drugs that cause deterioration in kidney function aren't always the easiest to use or the most attractive treatment. So I think the big question mark still about that drug. What about devices? Well, obviously there's no new major device development since 2016, but there are some subtle changes in the guidelines in terms of recommendations for devices. So to the right, you see the 2016 recommendation. To the left of the screen, as you look at it, you see the 2021 recommendation. So ICDs in patients with a non-ischemic etiology have been downgraded from a class 1 to a class 2A, and that really reflects the Danish trial, which failed to show a reduction in mortality with an ICD in extremely well-treated patients with a non-ischemic etiology. So they still have a class 1 recommendation for patients with an ischemic etiology, but the recommendation is less strong in patients with a non-ischemic etiology. And likewise, the recommendation for CRT has been weakened a bit in patients with modest increase in QRS duration. So although it remains a class 1 recommendation in individuals with a QRS duration of 150 milliseconds or longer, in those with a QRS duration between 130 and 149, the strength of recommendation has been reduced to a class 2A, and that reflects some of the new meta-analyses examining all of the trials and looking at where the benefit of this treatment seems to be most clearly observed, and that is in those individuals who have a very wide QRS duration with the left bundle branch block configuration. And then lastly, you can see here in terms of device interventions, you can see that there is a strengthening of the recommendation to what you might call upgrade conventional pacing in patients with heart failure who need the conventional pacemaker, upgrade that to CRT. So that's gone from a 2B to a 2A because of some more data suggesting that if a patient with heart failure needs a pacemaker for bradycardia, then it's probably better that that patient gets CRT than a conventional pacemaker. So what else is new? Well, I said I would come back to patients with heart failure and mildly reduced ejection fraction. And I mentioned that these more resemble HFrEF patients than people with a relatively normal ejection fraction. And I also mentioned that we have now some evidence that it looks like drugs that we use in people with HFrEF maybe also are of benefit in these patients in the mildly reduced ejection fraction category, roughly 40 to 50. And here are 3 analyses that we've done looking at the CHARM program with candesartan, looking at 3 MRA trials. This is RALS, emphasis heart failure, and TopCat, Americas. And then over here, sacubitril valsartan, the Paradigm and Paragon heart failure trials. This greeny blue line, turquoise line, shows you a continuous hazard ratio. The gray shaded area is the 95% confidence interval. And you can see here that this hazard ratio remains clearly below 1, which is shown here. The black horizontal line is unity. So the hazard ratio is clearly below 1, indicating benefit to an ejection fraction of maybe 55, even 60%. It differs a little bit for these 3 treatments, but you can see in all cases, the hazard ratio is clearly below 1 in patients, certainly in the 40 to 50% ejection fraction range. Now, of course, these are retrospective post hoc analyses. In essence, they're subgroup analyses. It's not the same as doing a prospective randomized controlled trial, but you do see here, I think, pretty consistent evidence. And as a result of that, in these new guidelines, really for the first time ever, there is now a recommendation. Again, it's relatively weak, so it's a 2B, may be considered. It's a level C, so it's a consensus opinion. It's based on those retrospective analyses. But there is a 2B recommendation for all of the drugs that we would use in patients with HFrEF now to consider using those in patients with heart failure and mildly reduced ejection fraction. So that really is a big change. I suspect it may be a little bit controversial, but nevertheless, it's something completely new. It is interesting because for a number of reasons. One is I'm not personally convinced that there is much data for beta blockers, but they got included in that recommendation. And of course, the ESC guideline recommendation for sacubitril valsartan differs from the recent US Food and Drug Administration expansion of the indication for sacubitril valsartan, which now says that this treatment or this combination of treatments is indicated in patients with an ejection fraction that is below normal, which at least in women is probably 60%. So again, a slight discrepancy between Europe and what's currently the recommendation in the United States or labeling in the United States. I think we're going to hear a lot more about this. I suspect that whole concept of mildly reduced ejection fraction is going to continue to evolve, and I personally suspect that the upper end of that range is going to increase from 50 to 60, but that's for the next guideline. So what else is there? There's updates on the non-cardiovascular comorbidities. Probably the most important of these is in relation to intravenous iron. As you all know, this has been shown to be a benefit in patients with HFrEF in terms of symptoms and in terms of functional capacity and quality of life. And remember, this is two things probably to remember. One is that you can be iron deficient without being anemic. So the guidelines make a strong recommendation to screen everybody for iron deficiency. And please remember also that oral iron doesn't work. It has to be intravenous iron. And the new bit of evidence incorporated in the 2021 guidelines is in relation to the first of a number of trials looking not just at symptoms and functional capacity, but now looking at morbidity and mortality. And that trial was the AFFIRM-AHF trial. It was one of 3 recent positive trials in hospitalized patients with heart failure, published in the Lancet last November. Didn't quite meet its primary composite endpoint, but if you look at total heart failure hospitalizations, or indeed if you look at a traditional time to first composite endpoint, you can see that there was a significant benefit. So heart failure hospitalizations were reduced by about 26%. This was a relatively small trial, as you can see, around 1,100 patients. It had a fixed follow-up of 1 year, so there were not very many cardiovascular deaths. It really was not powered to show an effect on cardiovascular mortality. So we'll have to wait for that information, but we do see this benefit on heart failure hospitalization. And that is now reflected in the 2021 guidelines. You can see here there is a class 2A, which is quite strong, should be considered level B. So there's one trial, I've just shown that trial to you, a class 2A level B recommendation to give hospitalized patients who are iron deficient intravenous iron therapy. And by the way we have checked for iron deficiency in these patients is to look at serum ferritin and transferrin saturation. And I must say that is something that I've been doing routinely for a number of years, but it's good to see it cemented in the guidelines. There's more coming, so there will be 3 more trials with intravenous iron therapy reporting in the next couple of years. So we're going to have very soon a total database of around 7,000 patients with heart failure randomized to intravenous iron or placebo. So we'll soon know a lot more, including about mortality. So what else? These are the other key changes for comorbidity. I don't think I'll go through all of these in detail because none of them really, I think, matter very much. So for example, beta blockers are less strongly recommended for control of ventricular rates in patients with heart failure, reflecting the meta-analysis that suggested that beta blockers might not reduce mortality in HFrEF patients who've got atrial fibrillation. Oral non-vitamin K oral anticoagulants or direct oral anticoagulants have got a stronger recommendation than previously, I think, reflecting the fact that we now all believe that these are better than warfarin for the majority of our patients. Coronary revascularization was downgraded a little bit, I think, reflecting some of the recent trial data that maybe for most patients with coronary disease, medical therapy is as good as revascularization in terms of improving prognosis. And of course, not surprisingly, in diabetes, SGLT2 inhibitors got a very strong recommendation. The new guidelines do, when it comes to comorbidities, have, I think, some nice updated and in some cases completely new treatment algorithms. Here's one for management of angina. Here's one for management of atrial fibrillation, and not surprisingly, catheter ablation, pulmonary vein isolation gets a much stronger recommendation than previously. In terms of acute heart failure, there are some nice new algorithms, but there are not really many treatment changes that matter very much. Diuretics are recommended a bit more strongly. Vasodilators, the treatment recommendation has been weakened because of really continuing evidence that these drugs probably don't do very much for most patients with acutely decompensated heart failure. Opiates are now contraindicated because of concerns that they may increase mortality, although I have to say this is largely based on observational data. Mechanical support has got a somewhat stronger recommendation, again reflecting the increasing evidence that we can use mechanical support in these patients, even as a short-term bridge to more definitive intervention. So that's probably all I'm going to say about the guidelines. There are lots and lots of areas that I haven't got time to cover. There's a lot of, I would say, very specialized text about heart failure in pregnancy, myocarditis, cancer in heart failure, a whole new section there, a lot about genetic testing, and then, of course, a new section on cardiac amyloidosis, reflecting the evidence with tafamidis for patients with transthyretin cardiac amyloidosis. So a lot more in the guidelines if you're interested in those areas, and this also explains why the guidelines have become a lot longer than they were in the past. So switching gears, I'm now going to talk about what was actually new at the ESC Congress. And I have to say, sadly, made the guidelines that I've just shown you out of date almost immediately. And for that reason, you may or may not have heard that the ESC made an announcement on the Friday, the first day of the Congress, Friday night, that very unusually they were going to update the heart failure guidelines within the next 2 years. ESC guidelines work on a 5-year cycle, but as of this Congress, the heart failure guidelines are going to be updated within 2 years, and you'll see why that is in just a moment. Because the big news at ESC in heart failure, by far the biggest story in heart failure, was the Emperor Preserved trial, presented and published simultaneously. This was the sister trial to Emperor Reduced. So it was a much larger trial with empagliflozin in patients with an ejection fraction of above 40%. And here you can see the design of the trial. So importantly, it included patients with an EGFR as low as 20 mils per minute. To get into the trial, in addition to having an ejection fraction above 40%, patients had to have a mild elevation of natriuretic peptides and either structural heart disease or a recent heart failure hospitalization. Structural heart disease means left atrial enlargement or left ventricular hypertrophy. This trial had the same primary composite endpoint as Emperor Reduced, so time to first occurrence of cardiovascular death or heart failure hospitalization. The median follow-up period was longer. In Emperor Reduced, it was only 16 months. Here, as you can see, it was 26 months. These are the patients enrolled. Very quickly, the key things I think to note are patients are about 6 years older on average than in Emperor Reduced, reflecting the fact that patients with heart failure mildly reduced and preserved ejection fraction are older. 45% of patients were women. In Emperor Reduced, it was about 25%. Again, reflecting the fact that particularly when it comes to heart failure with preserved ejection fraction, maybe even the majority of those patients are female. Once again, this was a trial including patients with and without type 2 diabetes, so about half and half. And you can see here that the EGFR was considerably lower than in the HFrEF trials, so 61 mils per minute. In the HFrEF trials, it was around 66 mils per minute. Half had an ejection fraction below 60. In DAPA-HF, it was about 40% patients had an ejection fraction below 60. So somewhat different patient profile. Here is that primary composite endpoint. So significantly reduced, 21% relative risk reduction. So just remember, this is the first ever trial in heart failure with preserved ejection fraction, or preserved and mildly reduced ejection fraction, that has been positive and clearly positive, no question about this. Very low p-value. Again, that very early onset of benefit that we're used to seeing now with SGLT2 inhibitors. In fact, I believe these curves were different within 18 days. Small number needed to treat. Only 31 patients need to be treated over the median follow-up of 26 months to prevent one of them experiencing cardiovascular death or heart failure hospitalization. So a really tremendously important breakthrough in heart failure therapeutics. Sadly, the main benefit, though, was on heart failure hospitalization, a large 29% relative risk reduction in heart failure hospitalization, but no clear benefit in cardiovascular mortality, although, as we're now used to seeing in our trials in patients with HFpEF, the risk of cardiovascular death was relatively low, 3.8 per 100 person years compared to 6 per 100 person years for a first heart failure hospitalization. So this is a disease, as we have said many times before, where the principal problem is heart failure hospitalization, indeed recurrent heart failure hospitalization. And here you see total heart failure hospitalization. So this is first and repeat admissions to hospital reduced by 27%. Again, a very highly statistically significant benefit. And look at that. These Kaplan-Meier curves seem to separate almost within, again, a week or two of starting treatment. So as we've seen in HFrEF, clear, early, substantial benefit, although unlike HFrEF, seems to be primarily on heart failure hospitalization rather than on mortality. The other secondary endpoint in EMPEROR preserved was the rate of decline in eGFR over time. And once again, same story. In fact, these graphs look almost identical. These figures look almost identical to the HFrEF trials. You see this early dip in eGFR, small, partially reverses, and thereafter the rate of decline of eGFR is substantially lower in the SGLT2 inhibitor treated patients compared to the placebo treated patient. In fact, if you look here, you can see that it's about half the rate of decline in eGFR over time. Again, I believe for the practical management of patients with heart failure, a very, very important development. And I would say just as important was the safety and tolerability profile. Now, you remember I said the average age of these patients was about 72. They were multi-morbid. If there was any group of patients who might have got into trouble with a new treatment, it was these patients. But here you can see, as in the reduced ejection fraction trials, the tolerability profile was very favorable indeed. There was no excess of hypotension. Look at ketoacidosis, only 4 cases out of nearly 3,000 patients in the empagliflozin group, 5 cases in the placebo group. So actually there was 1 fewer case in the empagliflozin group, and it was a tiny proportion. Genital skin fungal infections, which we know are the most common adverse effect with this treatment, occurred in just over 2% of the empagliflozin treated patients and just under 1% of the placebo treated patients. So this was more common, but it was still infrequent in these patients. And of course, these data really are backed up by the soloist worsening heart failure trial, which we also know about. We saw last year. This was a trial in hospitalized patients, inpatients, and this trial also included patients with preserved ejection fraction. And we also know that we're going to get very shortly, in a few months' time, another very large trial with dapagliflozin reporting findings in patients with heart failure and an ejection fraction above 40%. There are some interesting differences between these two trials that we can talk about if we've got time. So the question is going to be whether or not in the new guidelines we should really be adding now an SGLT2 inhibitor to cover the spectrum of mildly reduced and preserved ejection fraction, and maybe an indication even to an ejection fraction above 60%. The Emperor preserved investigators did present some post hoc analyses looking at whether or not this benefit extended across the whole ejection fraction range, and they suggested that perhaps there is no benefit above an ejection fraction of 60 to 65%. But I think we need to wait to see the results of the DELIVER trial to make a more definite recommendation based on what the upper cut point should be for SGLT2 inhibitors. One other thing I'll mention about this group of drugs, since they are the major breakthrough recently in heart failure, is we presented a clinical trial update at the ESC Congress, and this is an examination of ventricular arrhythmias, resuscitated cardiac arrest, and sudden death. And you can see here that we showed that dapagliflozin reduced this arrhythmic composite outcome significantly compared to placebo. So we thought this was an interesting additional bit of information about the role of these drugs in HFrEF. So in the guidelines, you can see that there are practical recommendations a bit like this in the appendix that's published along with the main guideline document. One other trial quickly to mention that was presented at ESC, GUIDE-HF. This was another second trial using this little implantable pulmonary artery pressure monitor. It's implanted during right heart catheterization in a branched pulmonary artery. You can non-invasively measure pulmonary artery pressure using this monitor, and you can follow that over time. A previous trial in patients with more severe symptoms, class 3, who'd recently been in hospital, suggested that treatment guided by knowledge of pulmonary artery pressure measurements could result in reduced heart failure hospitalization, as you can see here. And the GUIDE-HF trial was designed to potentially expand the role of this monitoring approach to a broader population. So this trial included patients in NYHA class 2, and patients didn't have to be recently hospitalized. They could be randomized without a recent hospitalization if they had elevated natriuretic peptides. All patients, all 1,000 patients who were randomized, had the device implanted, but in only half of those patients was pulmonary artery pressure measurement made available to the investigators to act upon. So the treatment group are the patients where the investigator received regular pulmonary artery pressure measurements, and the control group were the patients who were managed in the usual way. And here you can see the overall pre-specified analysis of the trial, and it was not significant. The trial was not positive. There was no reduction in the primary composite endpoint. There was a strong trend, there's a strong trend to reduction in heart failure hospitalization, but it was not significant. Now, the investigators said that their trial was affected by the COVID-19 pandemic, and they pre-specified an analysis where they would look only at patients who were followed before the onset of the COVID-19 emergency in the United States. This trial was enrolled mainly in the US with a few Canadian sites. And in that more restricted data set, you can see here that the trial did appear to be positive with a reduction in heart failure hospitalization. Now, there was a lot of controversy about this at the ESC Congress and whether this was a valid analysis to do. And I would have to say my impression at the Congress was that the jury is still out on this approach to management patients. The very last thing I'm going to mention is a new trial that was published looking at the effect of a new non-steroidal mineralocorticoid receptor antagonist called finerenone. There are a few of these around, but this is definitely the lead compound in this new class of mineralocorticoid receptor antagonists. If you remember, these are supposed to be more specific for cardiac compared to renal tissue, may cause less hyperkalemia. And what we saw at the ESC was the second of two trials in a program which looked at finerenone in patients with chronic kidney disease and diabetes, many of which, of course, had concomitant cardiovascular disease, including in some patients heart failure, although the heart failure was not really well phenotyped. So the trial we saw presented at ESC was the Figaro DKD trial. This trial was slightly different than the earlier trial, Fidelio, and this trial had a primary cardiovascular outcome. The Fidelio trial had a primary renal outcome, secondary cardiovascular outcome. So here are the two trials side by side, looking at the primary cardiovascular outcome, which was a composite, as you can see here, of CV death, MI, stroke, or hospitalization for heart failure. You can see this very consistent effect in the two trials. If you put the two trials together, as was done in a pre-specified pooled analysis, you can see that the hazard ratio is 0.86, consistent with a 14% relative risk reduction, which was highly statistically significant. But when you break down the cardiovascular composite endpoint, you can see clearly that this was driven primarily by reduction in heart failure hospitalization. So there was a 22% relative risk reduction in heart failure hospitalization in the pooled analysis of these two trials, highly statistically significant. What was really fascinating was that they had a reasonably large subgroup of nearly 900 patients on background SGLT2 inhibitor therapy, and the treatment effect was entirely consistent in these patients. That relative risk reduction was really at least as large in people on background SGLT2 inhibitor therapy, so suggesting that finerenone will add to the benefit of SGLT2 inhibitors. Now, why am I telling you about trials in patients with diabetes and chronic kidney disease with finerenone? I'm telling you that because there is a new trial currently recruiting very rapidly indeed using finerenone in patients with heart failure and an ejection fraction of 40% or above. So again, very shortly, we should have the results of this trial, which is called Fine Arts HF, and that will add to all of our trials that we now have telling us about the use of all of these drugs across the whole spectrum of ejection fraction. So with that, I'll stop really to leave you on a hopefully positive note that all of these new data are going to be complemented in the not very distant future by hopefully more positive trials and, as I've mentioned, an early guideline update. Thank you very much.
Thank you, Professor McMurray. It was really wonderful. as enlightening as ever. So there are some questions which will be asked based on the guidelines, which seem quite new, and a lot of new things have come in. So my first question is that how did you decide to put RNA as 1B and SGLT2 as 1A? Both have enough evidence now. And RNA we thought was 1A throughout. Why suddenly 1B?
Okay, so I can give you my personal opinion, but that doesn't matter. It's what happened in the guideline committee that matters. And the guideline committee did not feel that the Pioneer study, which was the sort of second study with sacubitril valsartan, was sufficient to justify a level A of recommendation. If you remember, level A is 2 trials or a meta-analysis. The Pioneer study was a 900 patient, roughly 8-week study trial. It had a biomarker primary endpoint. It was not designed to look at clinical events, although it did show a reduction in clinical events, although the number of events was small. And the guideline committee did not feel that the Pioneer trial met the requirement that you need to meet to have a second significant large morbidity mortality trial. But of course, with SGLT2 inhibitors, we did have that. So we had both DAPIHF and Emperor reduced. So whereas with RNAs, we had only one very large trial. With SGLT2 inhibitors, we had 2 very large trials. So RNA got level B, SGLT2 inhibitors got level A. That's the reason, that's the rationale. Don't necessarily personally agree with it, but that's why you've seen what I showed you.
Thank you very much.
But don't forget, it's a class A.
Yeah.
Sorry, it's a class 1. Class 1. So that's what matters.
Second thing is, let me complete, Dr. Sir. So now that we have the results of the Emperor preserved study, it shows that in the mildly deranged, what used to be called as mid-range ejection fraction, the maximum benefit lies there. So would you think that now you have that study, would you put SGLT2 inhibitor, I would say empagliflozin because you have trial with that, as a 2A indication for using in patients with 40 to 50% ejection fraction at the present moment in time?
Well, again, speaking for myself, I would say yes, I completely agree with you. In fact, I wonder if these drugs may be useful even to a considerably higher ejection fraction. I think we need to wait undelivered to find out. I told you that the Emperor preserved investigators, as you probably saw, presented and indeed have published further analyses dissecting ejection fraction into small groups. And above 62.5, 65%, the treatment benefit seems to diminish. But I would really point out that in the above 65% ejection fraction category, for example, there were only 60 events in the placebo group. So it's a really small number of events, and you cannot be sure that that is a reliable analysis. So while I would say we're not sure about, let's say, 6% and above, we shouldn't dismiss the possibility of benefit. But your suggestion that in the range, certainly 40 to 50%, yes, I think we've got the evidence. And by the time we get the results of DELIVER, then I suspect it will be maybe even a class 1 and not 2A recommendation. I think it's very unlikely that the DELIVER trial will show a different answer than the Emperor Preserve trial. I would be amazed if it did.
So, Dr. Sade, before I give it to you, there's one question in the chat box, which is very interesting. One second. Which is, why are beta blockers being relegated? What's the reason that now, is it RNA and SGLT2 have done so well that beta blockers are now not getting that much importance as they
beta
were?
blockers. So beta blockers are not not really relegated. So beta blockers have a class 1 level A recommendation in HFrEF. That's as strong as you can get. That's unchanged. What has changed is the recommendation for a beta blocker for rate control in patients with atrial fibrillation. And that's been softened, downgraded a little bit. And that's, if you remember, there was this meta-analysis in the Lancet, again, I would say controversial, because it was a meta-analysis of all the big beta blocker trials in HFrEF, and it suggested that there was no mortality benefits with a beta blocker in patients with atrial fibrillation. Now, there was some benefits on non-fatal events, but it suggested that there was no clear mortality benefit. Now, we've had a lot of arguments about this. It's retrospective, it's subgroup. I'm very inclined to discount it and ignore it, but that's where that softening of the recommendation comes from. It's you know, people don't feel the same necessity to give a beta blocker to all patients with atrial fibrillation to control their ventricular rate.
Dr. Satya, what do you?
Yeah, Dr. Murray, when you talked about the 4 pillars, you know, if you see out of the 4 pillars, ARNI perhaps in our clinical practice is the only drug which really showed good clinical response and improvement in the ejection fraction as compared to the other, say, 3 drugs, though it has a 1B recommendation. So clinically, patients they really do well. So that one comment I want from you. And secondly, if somebody improves his ejection fraction, goes beyond 35, do you suggest we take them off the CRT or the transplant lists?
Okay, so your first question about ejection fraction. So we have evidence that ARNIs improve ejection fraction. We have evidence, and there is only one ARNI, sacubitril valsartan, improves ejection fraction. We have evidence that beta blockers improve ejection fraction. We have evidence that ARBs and ACE inhibitors improve ejection fraction. But strangely, we do not have good evidence that MRAs improve ejection fraction. They're the one group of the conventional drugs where we just don't have that evidence. Recently, we do have evidence that SGLT2 inhibitors improve ejection fraction. There are 3 left ventricular, more correctly, cardiac remodeling trials with SGLT2 inhibitors. 2 were MRI trials. One was an echocardiography study, and collectively they show that SGLT2 inhibitors do lead to favorable left ventricular remodeling. So out of all our pillars, the one that stands out in not having evidence for remodeling is an MRA. Now, that doesn't mean you shouldn't use an MRA. Of course you should. It saves lives. It reduces hospital admissions. But curiously, we just don't have that additional bit of information. I've forgotten what your second question was.
If you improve your EF and go beyond 35 and make it 40.
Yeah. Sorry. Sorry. So yes, I mean, obviously, if you improve your ejection fraction above 35%, then you no longer have an indication for CRT or for an ICD. And you remind me actually that you may have noticed I said that DELIVER has some interesting differences from Emperor Preserved. Well, one of those interesting differences in DELIVER, we very deliberately included patients with what we used to call heart failure with recovered ejection fraction. I believe we're now meant to call it heart failure with improved ejection fraction, but those patients that you're describing. And so we included patients who had an ejection fraction below 40% previously, but had improved with conventional therapy. And in the DELIVER trial, we have over 1,000 of those patients. 18% of the patients are those individuals. So I believe we'll be the first trial ever that will tell us something what you do if you have a patient like that, if you've got somebody who's improved with an RNA beta blocker and MRA, but remains symptomatic, is it worth then adding an SGLT2 inhibitor? So we'll have that information. And I think increasingly we're going to have to think about what to do with those patients, because we see so many of them. I think a lot of us feel that, particularly since the introduction of sacubitril valsartan, we've been seeing, when that's used in conjunction with a beta blocker, we've been seeing a lot of people with a substantial recovery of their left ventricular systolic function.
Balbir, any questions in the chat box? Dr. Balbir? And Dr. Murray, I mean, this is the answer which we know, but I want it to come from you. People tend to decrease the dose of ARNI, say somebody is at 100 twice a day, when they really improve their ejection fractions and they're doing very well. So I just want your comment. We know it, but I want it from you.
Well, I wouldn't do that. I mean, I'm a bit worried the messaging about dose has got confused recently, because it's sort of changed. So you know that recently there's been a lot of emphasis on the importance of getting all of these treatments started as quickly as possible together, and saying that even a low dose is fine and that dose titration can come later. It's a secondary consideration after getting all of the treatments on board, but it's still important. And the evidence from the trial still is that you should titrate to the target dose. And as you also know, for ACE inhibitors and for ARBs at least, and there's some softer data with beta blockers, there is randomized trial evidence that bigger doses give a larger benefit than smaller doses. Now, admittedly, it's a modest additional benefit, but there is some. So I would always try and titrate patients to the target dose, and I would certainly never reduce the dose. The danger, I believe, in reducing the dose is that the patient might actually deteriorate. And as you know, in the TREAD-HF study, where treatment was withdrawn, and that's obviously more extreme than reducing the dose, in that trial, the patients who were randomized to treatment discontinuation, gradual treatment discontinuation, did show deterioration both in terms of symptoms and in terms of their left ventricular function. So I think it's a bad idea to back titrate unless you have to.
I think the final question is that with this now new evidence of 1A and 1B, would you think of shifting a patient who is on ACE to ARNI to further improve his prognosis?
If the patient's ejection fraction was below 40% or 40% or below, then absolutely yes. And in fact, arguably, with the new guidelines, you would even say if the ejection fraction was 50% or below, you would think about doing that. And I mean, I sort of routinely do that. We don't even start today with an ACE inhibitor or ARB. We start with an RNA, and I think that's what most good heart failure centers practice today. And of course, if your patient is still symptomatic, you would definitely change. I would argue that even if your patient's asymptomatic, you should change, particularly if they've got a persistently low ejection fraction, because the evidence is that your survival is better with an neprilysin inhibitor. I mean, I think people forget again that when you're switching to an RNA, you're not really switching. What you're doing is you're adding a new drug. You're adding a neprilysin inhibitor. You might be switching the type of RAS blocker the patient's on. If they were on an ACE inhibitor, and you change the sacubitril valsartan, you're changing the RAS blocker, but you're adding a neprilysin inhibitor. It's the neprilysin inhibitor that is the new thing that further reduces mortality. So I think you want to give as many people as possible the benefit of neprilysin inhibition.
Thank you, Dr. Murray. I think that was a great session with you, and I think we'll move on to the next session with Dr. Peter Tout. It's a great privilege to introduce him today. He's the Director of Preventive Cardiology at the CGS Medical Center and the Professor of Clinical Medicine at the University of Illinois. He's the Adjunct Associate Professor of Medicine at the Johns Hopkins. In fact, he's currently the President of the American Society of Preventive Cardiology, the past President of the National Lipid Association, and he has a large number of publications to his credit. In fact, he's the author of several textbook chapters, and today we are privileged to have Dr. Toth with us, and he will give us insights into what was new at the ESC 2021. Dr. Peter, please.
Thank you, Dr. Sathe. Will the tech support be showing my slides?
So kindly share it if possible. Will you share it? Is it handy, or do you want us to share it?
Yeah, go ahead and put it up.
Yeah, all right. Okay.
And Dr. Sathe, my understanding was that this program was about 90 minutes. We're at 76 minutes. How much time do I have?
You have enough time. You have 94 minutes.
Okay, so you won't cut me off at 90 minutes.
No.
All right, thank you. And excuse me, I thought tech would have it up, so it's my fault. I should have asked ahead of time. I will be covering a very broad range of issues in my talk. John's talk was marvelous in terms of the depth into heart failure. I'll be covering things from lipids to diabetes to the use of DAPT post-stenting with modified stent. It's going to be quite a potpourri.
Saurav, are you sharing your slides? Dr. Murray, till that time, so when you see rapid sequence initiation of all your 4 pillar drugs, now how do you go about it today?
Why don't we let, I'd love to answer, but I don't think it's fair. I think we should move on to Peter's talk because his slides have just come up.
Okay, so let's start with Master DAPT. In this clinical trial, looked at the management of high bleeding risk patients who were stented with a bioresorbable polymer-coated stent. And let's see here. How do I advance? I can't advance. There we go. Okay, so these were all high bleeding risk patients treated with this Ultimaster stent, and they had no restriction based on clinical presentation or PCI complexity. Patients were randomized after 30 days from PCI to either abbreviated DAPT, which included just 1 month of dual antiplatelet therapy, followed by single antiplatelet therapy for another 11 months. Go back, and okay, there we go. And the other group was treated with standard DAPT for the full year following randomization. In order to be enrolled in the trial, I just want to go back. Okay. In order to be enrolled in the trial, you had to be free of cardiac and cerebral ischemic events and any active bleeding. Moreover, anyone enrolled in the trial would have no further revascularization planned for management. And I'm not sure why I'm not advancing. Okay. So what happens? Well, this is actually pretty good surprise here. Because you'll notice that when you look at the primary composite endpoint, looking at standard DAPT for the year versus abbreviated DAPT, which included DAPT only for 1 month, followed by SAPT, there's no between group difference. And the non-inferiority margin would have been 3.6%, but it's only minus 0.23%. And hence, the single antiplatelet therapy or abbreviated DAPT versus standard DAPT was shown to be non-inferior. Now, how about for major adverse cardiac and cerebral events? Same. Look at this. These Kaplan-Meier survival curves are beautifully superimposable. And the non-inferiority margin would have been 2.5% in this trial. It comes in at 0.11, and hence the use of this stent followed by abbreviated DAPT for just 1 month was not inferior to standard DAPT therapy. I am not able to advance, and I'm not sure why. I want to go to the next slide. Technical, I'm not able to advance. Can you please advance the slide? Can you advance the slide, please?
Saurav, technical support team, please.
Yes, sir.
Okay. All right. I need slide 5, please. Slide 5. Oh boy, this is a mess. Okay, slide 5. Yeah, okay. Put it back on presentation screen. Okay. Now, how about major or clinically relevant non-major bleeding? Here again, no surprise, if you're only going to use 1 antiplatelet therapy versus 2, we do anticipate that there will be less risk of bleeding. And in fact, you see this, it's quite a remarkable difference. Actually, a 2.82% absolute percentage difference. And you notice that these curves are separating immediately from time of randomization. And hence, in this particular analysis, abbreviated DAPT was shown to be superior to standard DAPT in terms of risk for major or clinically relevant non-major bleeding. And advance the slide, thank you. And hence, the authors concluded that for patients at high bleeding risk who had undergone implantation of a biodegradable polymer Ultimaster sirolimus-eluting stent, the discontinuation of DAPT at a median of 34 days compared to continuation of treatment for a median of 193 days after PCI was, number 1, non-inferior for the incidence of net adverse clinical events, non-inferior for the incidence of major adverse cardiac and cerebral events, and clearly was associated with a much lower incidence of major clinically relevant non-major bleeding. And next slide, please. Okay, now we have a study by George Dangus at Mount Sinai in New York. And in this particular study, in Envisage TAVI-AF, they compared edoxaban to vitamin K antagonists after transcatheter aortic valve implantation in patients with atrial fibrillation. And we'll see highlights here. I don't have the plots, but the non-inferiority criteria was met for the NACE primary endpoint. There were higher rates of major bleeding with edoxaban, and this was largely attributable to major GI bleeding. 1 major GI bleed was fatal in the edoxaban arm, and rates of intracranial hemorrhage or fatal bleeding were similarly rare in both trial arms. The patients who fulfilled dose adjustment criteria and received edoxaban 30 milligrams had similar adverse event rates compared to patients who were taking the vitamin K antagonists. and among patients with pre-specified antiplatelet therapy, edoxaban was associated with higher rates of major bleeding compared with BKA. I don't think that's necessarily surprising. Next slide, please. Okay, so an envisaged TAVI-AF in patients with an indication for oral anticoagulation for atrial fibrillation after a successful TAVI, edoxaban was not inferior to vitamin K antagonist for the primary composite outcome of adverse clinical events. And in these patients, edoxaban was associated with higher major bleeding risk. And sub-analyses suggest that patients fulfilling dose adjustment criteria in patients without concomitant oral antiplatelet therapy may be reasonable candidates for edoxaban based on attenuating bleeding differences versus control. Of course, they're looking at this in greater detail. That takes us to Tomahawk. Now, this is, I think, very interesting. And this looked at coronary angiography after out-of-hospital cardiac arrest without ST elevation. So what did they see? Go ahead, next slide. Next slide, please. Tech, may I have the next slide? Oh boy.
Saurav, tell those guys to be attentive, Saurav. Tech. Saurav, are you there? Where is the technical team? Saurav, technical team, please.
Yes, sir. Yeah, one minute.
Please
Sorry.
move the slides up.
Yes.
Please be there. Please share his slides and be there to move. Tech support, where are you?
Sorry, sir. 1 minute, sir. Sorry.
Well, Dr. Sate, I owe the audience an apology. I should have looked these slides.
Well,
This will go down as the worst talk Peter Toth ever gave.
Tech support team, where are you? Okay, Peter, till that time, when you are talking about withdrawing from dual antiplatelet to a single, now people have different combinations, aspirin plus clopidogrel, aspirin ticagrelor, aspirin clopidogrel. So which one do you leave when you swap from DAP to SAPT?
Well, it was the aspirin that they left. The idea behind the new stent was that you would be able to do away with the GP2B3A, continue with a simpler regimen of aspirin, which would, of course, be less expensive and safer because of reduced bleeding risk.
So in your practice, do you give maybe only ticagrelor or say prasugrel to patients who have had it, say, after 1 month or 3 months after that, after PCI?
No, this would apply only to that particular sirolimus associated stent, only to that one. Otherwise, the guidelines still apply in terms of duration of therapy. And I would argue that based on registry data, we still don't know what the optimal period of time is for dual antiplatelet therapy, because in some registry data, you still see a signal for excess risk even 2 or 3 years after stent deployment. So I would say that those data are relevant only to that particular stent type.
Okay.
Okay, so now we see in Tomahawk that when you compare delayed or selective angiography to immediate angiography when the patient is brought into the hospital after cardiac arrest, there is a trend for a difference, a 28% higher risk for the primary composite endpoint. Now, it did not meet statistical significance, but if we could have the next slide, please. You'll notice that actually all-cause mortality or sustaining a severe neurological deficit was actually 16% higher in the group that underwent immediate intervention. And this was in fact statistically significant. Now, in terms of MI risk, sustaining a severe neurological deficit, peak release of myocardial enzymes, moderate and severe bleeding, stroke, acute renal failure requiring renal replacement therapy. There were trends for each of these endpoints, but they did not meet statistical significance. Next slide, please. And so actually, very appropriately, the Tomahawk investigators concluded that among patients with resuscitated out-of-hospital cardiac arrest, of possible cardiac origin with shockable and non-shockable arrest rhythm and no ST elevation, a strategy of immediate unselected coronary angiography was not found to be beneficial over a delayed and selective approach with regard to the 30-day risk of all-cause death. And these findings in Tomahawk actually correspond very well with the COACT trial, which found no significant differences in clinical outcome between immediate and delayed coronary angiography at 90 days and 1 year. So taking a patient straight to the cath lab, if they've sustained out-of-hospital cardiac arrest, does not appear to confer any benefit, and in fact, may incur net injury. Next slide, please. Now, this one is really good too. Ripcord 2, this is interesting. So they looked at routine pressure wire assessment versus conventional angiography in the management of patients with coronary disease. Next slide, please. And interestingly, when you look at patients who undergo angiography only versus angiography plus fractional flow reserve measurement, there's no difference in total hospital costs at 12 months or quality of life when you look at these two plots. This is, I think, surprising to a lot of people because actually we have attributed value to fractional flow reserve measurement. If I could have the next slide, please. And so they concluded that routine systematic FFR assessment at the time of diagnostic angiography is actually cost neutral compared with the angiographic guidance alone. And there's actually no significant difference in quality of life or angina status at 1 year. They also showed that FFR of all epicardial coronary vessels significantly altered the clinical, it doesn't alter the clinical event rate or the distribution of management in terms of medical therapy, PCI, or referring the patient for CABG. Systematic FFR was associated with longer procedures, more radiation and contrast, and more complications to angiography alone. And so they conclude that this strategy had no advantage compared to angiography alone. And I'm sure this will be an issue of discussion, but the data are the data. And this is the first completed randomized trial of systematic FFR versus angio alone at the stage of the diagnostic angiogram. No benefit. And actually, they argue that it would be safer to just simply do the angiogram without FFR because it would be associated with less radiation exposure and less contrast. Okay. Now, here is another very interesting study which looked at carotid artery stenosis. This is the AXT2 done in the UK. Next slide, please. And here they compared carotid stenting versus carotid endarterectomy. They looked at 5-year risk of procedural death or of disabling or fatal stroke. On the left, you see here the analysis of stenting versus endarterectomy, including procedural risks, and on the right, excluding procedural risks. And you notice that they were not able to detect a difference between groups in terms of the primary composite endpoint of 5-year risk of procedural death or of disabling or fatal stroke in either group. Next slide, please. And they concluded that competent stenting and endarterectomy involve about a 1% procedural death or disabling stroke risk. And when you look at this particular clinical trial, where there's about a 0.5% per year actually have a fatal or disabling stroke with either surgery or stenting, and with neither procedure, about 1% per year would have done so. So you get about a 0.5% benefit with the procedure of stenting or surgery, which is very interesting. Next slide, please. Now, how about influenza vaccination? Now, here we are, we have a worldwide COVID epidemic, and we know that influenza kills many thousands of people every year. In the US, we lose about 35 to 50,000 people a year due to influenza related infection. And we've known for some time that patients with established cardiovascular disease actually derive significant benefit from influenza vaccination. And this particular group looked at influenza vaccination after myocardial infarction. And they asked the question, does influenza vaccination decrease risk of hard cardiovascular events? And they looked at patients with a recent MI or high-risk coronary disease. They looked at 8 countries, and they looked at 4 influenza seasons between 2016 and 2020, and they included about 4,500 patients. Okay, next slide, please. So what did they look at? The primary composite endpoint included all-cause mortality, MI, and stent thrombosis. Key secondary endpoints include all-cause mortality and cardiovascular death. They found that, in fact, vaccination was quite well tolerated, and the risk of hard cardiovascular events was reduced significantly. And they are recommending that influenza vaccination be provided to anyone as part of their in-hospital care subsequent to an MI. Okay, next slide, please. Okay, another dual antiplatelet therapy study. This is in patients with acute coronary syndrome. This is a study out of Japan, and they're looking at 1-month dual antiplatelet therapy followed by clopidogrel monotherapy. Next slide. So we see here, this is the STOP-DAPT-2 ACS trial. And this is, as you see in the randomization scheme, a study that looked at dual antiplatelet therapy for 1 month versus 12 months. And here, after 1 month, in the 1-month DAPT, they stop the aspirin and the patient is continued on clopidogrel. In the other arm, the patients received dual antiplatelet therapy for the full 1 year. Next slide. So what do we see? Well, actually, with 1 month DAPT versus 12 months, you'll notice that there is a statistically significantly higher rate of all-cause mortality at 49% higher. This was statistically significant, and this favored dual antiplatelet therapy. When it comes to cardiovascular mortality, no between group differences. And I'm sorry, the all-cause mortality was a trend not statistically significant, but there was a near 2-fold higher rate of MI that was statistically significant. And again, the patients with DAPT did better than with the discontinuation of aspirin after 1 month with continued clopidogrel therapy. If you look, go back please. If you look at risk of BARC 3 to 5 bleeding, clearly substantially higher with the DAPT, which we know, of course, is a risk. There's a trend for a higher rate of stroke There's a trend for a higher rate of ST segment elevating myocardial infarction. And there is a slight trend, and that's not so slight actually, 1.53-fold trend for a larger MI with a higher CK-MB elevation. So I think clearly 12-month DAPT here dramatically outperformed 1-month DAPT. And I think anyone listening to this or looking at these data, if it was them on the cath lab table, they will want the 12-month DAPT. Go ahead to the next slide. So in ACS patients who undergo successful PCI, clopidogrel monotherapy after 1-month DAPT failed to attest the non-inferiority to 12-month DAPT with aspirin and clopidogrel. And further investigations are needed to establish the optimal antiplatelet therapy after PCI in patients with ACS. And I think there's broad agreement about that. Next slide. Okay, now we'll take a look at a couple of studies that used rivaroxaban in patients with PAD. In both of these studies compared patients with and without diabetes. In this first one, we're going to look at the efficacy and safety of rivaroxaban in patients with PAD and diabetes after lower extremity revascularization. Next slide, please. And what they did here was they wanted to assess the consistency of efficacy and safety of rivaroxaban, vascular events, and bleeding on the basis of diabetes at baseline. And may I have the next slide, please? So these are the patients who are just on placebo. And no surprise, you'll notice that because the diabetic patients typically have a substantially higher risk factor burden, greater morbidity, they also do more poorly in terms of the primary outcome with a higher rate of major amputation of vascular cause, MI, ischemic stroke, or cardiovascular mortality. And you notice here that there is a very substantial difference between diabetics and non-diabetics in terms of this primary composite endpoint for those on placebo. Next slide. Now, how about if you look at patients who are then treated with rivaroxaban and they are or are not diabetic, and you're looking at the primary endpoint, and actually here, the results are, of course, quite encouraging. If you look at patients with no diabetes, with diabetes, the patients with no diabetes achieve a 21% improvement in the primary composite endpoint. That is statistically significant. Among the diabetics, there's a trend, but the P value for interaction is 0.16. So no between group differences, and hence there is benefit to be had. Next slide. Now, how about if you look at the safety? And again, obviously, if you're piling on more things that have the risk for potentiating bleeding, you're going to see it. And no surprises here, really. When you look at placebo versus the rivaroxaban, you'll find, of course, that risk of TIMI major bleeding with diabetes, you over triple that risk. You increase it 2.5-fold, statistically highly significant. TIMI major without diabetes, interestingly, not much of a change. Now, we know that the patients with diabetes, they can have altered coagulation factor expression, altered platelet activity, and the like. But there's also higher likelihood that they will also be on aspirin and clopidogrel because of underlying coronary disease and other comorbidities. Now, when we look at patients with patients with diabetes, intracranial hemorrhage or fatal hemorrhage with diabetes, 1.67-fold, but not statistically significant. And when you look here at intracranial hemorrhage or fatal without diabetes, the diabetics had a slightly lower trend, but no statistically significant difference. Where we do see some statistically significant differences are once again in the diabetic group. where you're finding a higher risk of BARC3B and above risk of bleeding in the diabetic patients, 1.8-fold higher rate among the patients given rivaroxaban versus placebo. And then when you look at the patients who have major risk of bleeding, again, it's going to be with the diabetics, but for the non-diabetics, it was not statistically significant. Go ahead. So subjects with PAD who have diabetes have a different baseline risk with more hypertension, CAD, critical limb ischemia, lower GFR, and more clopidogrel use, and are at extremely high risk of adverse events of the heart, limb, and brain after LER. And the efficacy of rivaroxaban was consistent regardless of diabetes status at baseline. However, a higher rate of discontinuation among these patients may have attenuated the observed benefit. The diabetic group did not achieve statistical significance, but there was no between group difference that was statistically significant in terms of being diabetic or not diabetic. Risk of TIMI major bleeding was greater in the diabetic group versus not being diabetic. And again, this is possibly driven by different baseline risk associated with bleeding and or the low rate of bleeding observed in diabetic patients randomized to placebo. And of course, additional analyses are planned. Next slide. Here we're looking at the risk profile and efficacy and safety of rivaroxaban in fragile PAD patients after revascularization. Insights from Voyager PAD. Next slide. All right. So in Voyager PAD, rivaroxaban 2.5 milligrams twice daily versus placebo on a background of low-dose aspirin and possibly clopidogrel, depending upon clinical circumstances, in symptomatic PAD after lower extremity revasc, reduced irreversible harm events of the limb, heart, and brain, increased bleeding but not intracranial hemorrhage or fatal bleeding, and had a 6-to-1 benefit ratio. So now they're going to look at key populations, namely the elderly and, quote, the fragile, age over 75, weight less than 50 kilos, and our baseline estimated GFR of less than 50 milliliters per minute, which is an interesting definition of fragile. And so the aim was to describe the efficacy and safety of rivaroxaban in fragile patients with symptomatic PAD after lower extremity revascularization. Next slide. So we already mentioned the top-line benefits from Voyager PAD. And although age and fragility were associated with an increase in ischemic and bleeding risk and have been proposed as factors for patient selection, the efficacy and safety of rivaroxaban was consistent regardless of these factors, with positive net benefit with the rivaroxaban therapy. In patients with symptomatic PAD after LER, rivaroxaban should be considered regardless of age or fragility. So that's good news. Next slide. Now for the ESC guidelines. There's a lot here, as always. They're extremely well done. And try to take you on a quick summary of this. Next slide. So this is a very comprehensive approach to CVD prevention. So obviously the first step is identifying patients. If they have established ASCVD, diabetes, they have CKD, familial hypercholesterolemia, or they're apparently healthy. And if they're apparently healthy, then calculate a 10-year CVD risk. And in Europe, they use the SCORE system. And they want you to consider risk modifiers, overall CVD risk, and treat the risk factors to risk stratified goals. Clearly, for patients with ASCVD, the picture is more complicated, and you want to identify all risk factors comprehensively and treat to guideline-directed goals. Similarly, for the diabetes and for the patients with CKD and FH. For the patients with FH, I just want to emphasize that you don't have to do genetic testing in order to make the diagnosis of FH. It is adequate to simply use the cut point of 190 milligrams per deciliter, which would be approximately 4.5 millimoles per liter. This is adequate. The other point here is that just like the American system, they are now recommending that in addition to using the score system, if there are other emerging risk factors, if there are risk factors that are not accounted for in the score system, that you can use that as risk modifiers. Next slide. All right, so they are breaking this out by age group, estimating 10-year CVD risk. And then once the risk is stratified to less than 2.5, 2.5 to less than 7.5, greater than 7.5%, obviously that influences how aggressive you are in the management of their lipids. Blood pressure, they want systolic blood pressure between 130 and 140 millimeters of mercury. And again, there's a whole new emphasis on risk modifiers, consideration of calculating lifetime CVD risk, especially among younger patients, and then looking at overall treatment benefit and being sensitive to patient preferences. The difficulty with being sensitive to patient preferences is that patient preferences are not necessarily informed by the most recent clinical trials or understanding what specific drugs do and how they benefit the patient. So in order to fill all that out, it's extremely important that the patient be counseled on optimal approaches to how these risk factors should be managed, how aggressively, and what kind of benefit they can expect in terms of specific reductions in blood pressure or hemoglobin A1C or LDL, and making sure that they understand this before they consider rejecting a specific therapeutic intervention because they want to use something, quote, more natural or holistic, which obviously can dramatically impair their future. Next slide. Okay, among the lipid recommendations, if a patient is on a maximally tolerated dose of a statin and their LDL target is not achieved, consider the addition of ezetimibe. If they still can't get to target, consider the addition of a PCSK9 monoclonal. I get the fact that PCSK9 monoclonals can be very difficult to obtain in many countries in this world. But bottom line is statins are horrifically underutilized and under-titrated. And we're really not doing the patient many favors by keeping them on a low-dose statin to either reassure them or reassure ourselves that they're not going to develop side effects. We now know, based on the N+1 trial, that 90% of statin intolerance is due to the nocebo effect, meaning the development of negative expectations surrounding a therapeutic intervention. So with appropriate counseling and reassurance, we can do a much better job of keeping patients on their statin, titrating that statin, and then evaluating whether or not they need a secondary intervention. And initiation of statin treatment for primary prevention in older people aged greater than 70 may be considered if at high risk or above. I actually profoundly disagree with this. I don't care how old you are, if you're functional, your heart and your mind are still good, and you want benefit because your cholesterol is high, and you didn't know that before, I would never withhold a statin based on age alone. Now, if there are extenuating circumstances and the morbidity is high, sure. But just because someone is older doesn't mean that you withhold a statin if they warrant therapy. Next slide. Thank you very much. Okay, now of course everyone needs to stop smoking, exercise, etc. If they're diabetic, we want their A1C at least less than 7, optimally less than 6.5, and if they can tolerate it, closer to 6. Why? Because the closer you get it to 6, the lower the likelihood that they're going to develop microangiopathy with retinopathy, nephropathy, neuropathy, and also the macrovascular complications of diabetes, which of course include atherosclerotic disease, not only in the coronaries, but also peripherally. And now they also want you to consider not only do they have ASCVD, but do they have target organ damage? And this is actually very valuable because if they have target organ damage with retinopathy or nephropathy, and the list is long, then you need to treat even more aggressively. And this makes tremendous sense. The other thing that they are now emphasizing, which again is extremely important, is among diabetics, if they have established heart failure or atherosclerotic cardiovascular disease, this of course goes a long way toward determining whether or not you should institute an SGLT2 or a GLP-1 receptor agonist early in the course of their management. John already showed beautiful data with the SGLT2s, both in diabetics as well as non-diabetic patients. The GLP-1s truly are a remarkably effective drug class for patients who have established atherosclerotic cardiovascular disease. We know from such studies as LEADER, as SUSTAIN-6, and also from REWIND, that drugs like liraglutide, semaglutide, dulaglutide, they provide significant endpoint reduction in terms of cardiovascular events. And in some cases, this can be quite dramatic. In SUSTAIN-6, 39% reduction in stroke, 36% reduction in the need for coronary revascularization, even a 35% improvement in rate of nephropathy progression. For patients with underlying nephropathy and they're diabetic, the SGLT2 is going to be your first choice. But don't forget, in SUSTAIN-6, there was also a nephropathy benefit with the GLP-1. Obviously, most diabetics are going to have both underlying ASCVD and heart failure. They're at profound risk for systolic dysfunction because of progressive myocardial insult from their coronary disease, diabetic cardiomyopathy, etc. And most of them are going to have concomitant CAD with their heart failure if they have heart failure. Next slide, please. All right, now, if they have no ASCVD or target organ damage, then you see here, based on risk, we do or do not intensify therapy. I'll tell you how I manage my diabetic patients. I make sure their systolic blood pressure is less than 130. I also make sure that their LDL is definitely less than 1.8 millimoles per liter, and preferably I drive it much lower than that. And if they have ASCVD or heart failure, I am extremely fastidious about making sure that an SGLT2 or a GLP-1 receptor agonist is at least second-line therapy after metformin. And if they don't tolerate metformin, it's going to be first-line therapy. Among patients who have a history of MI, they have upcoming interventions. In addition to the DAPT, that they will receive subsequent to, say, stenting, EPA also is a very viable choice, icosapentaenoic acid, among patients whose triglycerides are simply over 150. We know from the REDUCE-IT trial that this EPA can dramatically impact risk for cardiovascular events over the next 5 years. And of course, the data with colchicine has become more and more promising, with 4 studies now out showing its efficacy in post-MI patients. All right, now how about for the diabetes? I already told you about the GLP-1, the SGLT2. That's the big one. But also remember that it does matter how much you lower that A1C. A1C equals life, and the lower you can safely drop that A1C, the lower the risk for microangiopathy and for macroangiopathy. And please remember, of course, diabetes is the #1 cause of adult onset blindness and the #1 cause of requiring dialysis or kidney transplantation throughout the world. Next slide. And how about for diabetic patients with heart failure and reduced left ventricular ejection fraction? Well, John already told us about this. I cannot do any better than him. Obviously, these drugs are extremely important for reducing risk in that setting as we saw in EMPA-REG and other studies, not only for heart failure hospitalization, but dramatic reductions in risk for all-cause and cardiovascular mortality. Okay, next slide, please. For patients with established ASCVD, no brainer, don't smoke, get the LDL down, get the blood pressure down, and antithrombotic therapy, aspirin monotherapy, if their overall, aspirin monotherapy with ASCVD if they haven't been stented, but obviously if they're stented, DAP therapy for a year. Okay, next slide, please. Okay, now I love the European guidelines because they're so much more aggressive than the American guidelines, especially when it comes to lipids. So if you have a very high-risk patient, let's say patient has had an MI, they got multivessel disease, they've been revascularized. The European guidelines are much more aggressive. They want a systolic blood pressure less than 130. They want an LDL less than 55. And in fact, if a patient has had an event and they have another event within 2 years, they want the LDL less than 40 or less than 1 millimole per liter. Now, people puzzle over that, but bottom line is all the latest data when it comes to LDL teach us that not only is lower better, but lowest is best. The lower you take LDL, the lower the risk. And in fact, you can take it all the way down to 0.25 millimoles per liter, 0.1 millimole per liter, and you still find incremental benefit. The relationship between LDL and risk is linear. There's no J curve, there's no U curve, there's no thresholding. It's all the way down to zero. So bottom line here is the worse the disease, the lower the LDL should go. And as we'll see now, in addition to SPRINT, we have a study out of China that showed that clearly among your high-risk patients, older patients, systolic blood pressure less than 130 confers greater benefit than between 130 and 140. Next slide. All right, the LDL lowering, we've already been through this. In terms of reducing the intensity of inflammation. This is interesting because now the Europeans are saying low-dose colchicine at 0.5 milligram every other day may be considered in secondary prevention of CVD, particularly if other risk factors are insufficiently controlled or if recurrent CVD events occur under optimal therapy. Wow, that's really amazing. But the US has not yet followed suit with this, but I think it's a very reasonable recommendation. As you see, they give it a class 2B. We've got 4 studies that show unequivocal benefit in patients with elevated baseline CRP, and especially among those who sustain a myocardial infarction. So this is new. To my knowledge, this is the only organization that has yet made this recommendation, but I think it is a good one, and I think it's reasonable given the weight of the data. Next slide. And that takes us to the STEP trial. This was done in China, and it looks at blood pressure control in elderly patients older than 70. Next slide. And this particular trial included over 20,000 patients. It's now published in the New England Journal of Medicine. Next slide. And they compared blood pressure of 110 to 130 compared to 130 to 150. Now we know from SPRINT there's clear benefit in lower blood pressure, though there's a risk of hypotension. But here we look at the primary composite endpoint with the hazard ratio of 0.74 comparing standard treatment to intensive treatment. So the lower blood pressure, in fact, was more beneficial. And when we go to the next slide, we see happily that there is a 33% incremental reduction in stroke, a 33% incremental reduction in the risk for an acute coronary syndrome, a 73% incremental reduction in heart failure. Wow. Now, we've talked a lot about heart failure today, but if you can prevent heart failure by keeping blood pressure between 110 and 130 as opposed to 130 to 150, and you can reduce that by 73%, that is simply extraordinary. And it's something I think we all have to pay much greater attention to, because I think the day where we say, that blood pressure of 140, 142, that's not so bad. And you're older, you're 75, we don't want to drop it too much. And when you look here at major adverse cardiovascular events and mortality from cardiovascular causes, both another 28% reduction, this argues very strongly for reducing blood pressure more into the 110 to 130 range. These are remarkably strong data. Next slide. In terms of safety, the only signal here that was statistically significantly different was the hypotension. And as noted on the previous slide, there was no between group differences for atrial fibrillation, with a little bit of a surprise, because obviously if you're reducing blood pressure, you're going to expect fewer changes in left atrial volume and dimensions, which you would expect to be somewhat protective against the development of atrial fibrillation, but they did not see benefit for AFib or for all-cause mortality. Okay, next slide. Lowers better again, not only for LDL, but also for blood pressure, and lowers better also for hemoglobin A1C. So we were never meant to have LDLs of 3 and 4 millimoles per liter. We were not meant to have blood pressures that are 140, 160, 170 millimeters of mercury. And we were not meant to have A1Cs of 7.2 and 8. Lowers better. Go ahead, next slide. That takes us to SAS. Now, this is also a nice surprise, because guidelines for years have been touting the value of substituting potassium-based salts for sodium-based salts. And some of the data has been based on the DASH type diet. But the bottom line here is we have needed a really strong study to demonstrate for us that substituting potassium for sodium in salt actually reduces risk for future cardiovascular events. And actually it did. And they were able to show that it reduced risk of stroke, major cardiovascular events, and premature death. And they didn't induce hyperkalemia. So for the people who are concerned that substituting potassium chloride for sodium chloride could lead to an elevation in potassium chloride in serum potassium, it didn't happen. Now, if someone is on a mineralocorticoid receptor antagonist, I would definitely want to study showing that it's safe before I did this. But for the average patient with hypertension who doesn't require MRA therapy in the setting of heart failure, certainly this is really good news. And so the authors of the study actually recommended some implementation strategies to help increase the consumption of a salt substitute that is potassium-based. And they state that salt manufacturers and retailers worldwide could switch to producing and marketing salt substitute at scale. Food processing industry worldwide could reformulate products to lower sodium and higher potassium compositions. Governments worldwide could design policies to promote salt substitute and discourage regular salt use. And consumers worldwide could cook, season, and preserve foods with salt substitute, not regular salt. And for those people who like salt substitute, it actually doesn't taste that much different. Okay, next slide. And this takes us to the end. And bottom line is, this was a cardio-oncology study called Pronounce. And they looked at the cardiovascular safety of daguerreolex versus a Lupron type GnRH antagonist. And it's a very important study, but the problem is they had to terminate it prematurely because they couldn't get an adequate number of participants. They did not see an appropriate number of events, and they were not able to detect any difference in the rate of cardiovascular events at 12 months between patients assigned to either daguerreolex or the leuprolide. So that study was a bust, but certainly it's a study that needs to be done. Okay, now, I am done, Dr. Sathe, and I want to apologize to our audience today for what happened during the first 10 minutes of this talk. I promise I will not let that ever happen again, but I think we picked up the pace and ended pretty well.
Yeah, thank you, Dr. Todd. I think that was an excellent overview of a large number of trials which have significant clinical relevance. We'll just discuss a few. And the first one is, as you mentioned, the ACCET-2. And you showed that carotid endarterectomy or stenting have the same results. But I want to ask you, what about finally, what is your take on asymptomatic carotid stenosis? Because you showed that the difference between these two therapies and medical management is just 0.5% per year. In India, we do a lot of bypasses in the elderly, and there's a trend to do a routine carotid Doppler. And if they have significant stenosis, people suggest a stent before a bypass. So with this data, what is your final take on asymptomatic severe carotid stenosis? Should we do or should we not do with that 0.5 difference at the end of 1 year?
Yeah, that was an astonishing finding. Did that surprise you, Dr. Sathe?
Yes.
Yeah, that's a pretty low rate. So I think we need more studies on this. It's just one study, and we need a lot more patients. And I think it would benefit us to see studies from different parts of the world, because obviously there are different practice patterns. But based on that study, I would say it doesn't make a lot of sense to stent the carotid if it's asymptomatic before you do a bypass.
Okay. The second is, again, your views on influenza. Influenza vaccine for last 2 decades, a lot of RCTs had come which were negative. Now, with this particular randomized RCT, do you think it will impact our clinical practice? I mean, because it will take a long time for it to come in the guidelines. So what are we supposed to do? Or look at only high-risk patients in winter season? Or what do you do with this? What do you think of this study for influenza vaccine in MI?
Oh, I think the study is quite valid. It was done in 8 different countries, 4,500 patients. And for patients who had sustained an acute MI, there was clear benefit across the board in terms of cardiovascular outcomes. So anyone, based on that particular trial, anyone who sustains an acute MI, they should be really targeted for influenza vaccination every year. I mean, I emphasize to all my patients, irrespective of whether or not they've had an MI, to always get the influenza vaccination. It is cost effective, it saves lives, and it dramatically reduces influenza season morbidity, loss of time at work, etc. And if a virus, an influenza virus infection, has such an impact on risk for hard cardiovascular events in patients who have sustained an MI, it is remarkably unintelligent to me to not give that vaccination.
Okay, great. Now you are very aggressive about statins in the elderly. Now, suppose you have done a stenting in a patient who is, say, 75 plus 80. What is your dose modification? Are you still aggressive with moderate to severe doses, or in the elderly, does it make that difference for secondary prevention and for primary prevention? What is your advice to clinicians?
Yeah. So, well, first of all, let me just preface the answer with, even in the US, only 56% of patients who are older than 65 who sustain an MI receive a statin, which to me is horrible. We know that statins reduce risk of MI, stroke, the need for revascularization, all causing cardiovascular mortality. The benefits are there. And we also know that these agents work in people older than 70 based on results from the heart protection study, as well as the PROSPER trial. those data were unequivocal. So it is extremely important that we protect our more elderly patients. And if we take the example of Indian patients, we know that based on the pharmacogenomics of Indian people, on average, they can get by with about half the dose of a statin as Caucasian Western Europeans. So when we talk about high dose, high potency statin therapy, basically, instead of saying atorvastatin 40 to 80 or rosuvastatin 20 to 40, you can be talking more like atorvastatin 20 to 40, rosuvastatin 10 to 20 in people of the sub-Indian continent. So I think you can get away with lower doses, but it's extremely important that you drop the LDL appropriately. In the European guidelines, it's greater than 50%, but if they are high risk, they've had an MI, at minimum, it should be less than 55. And if they have another event within 2 years of the first one, it's less than 40 in the European guidelines.
In fact, but to get the LDL to 55, somebody has say 130, you have to have PCSK9, isn't it? I mean, otherwise, with the statin therapy and ezetimibe coming to 40, it's difficult. Of course, that depends upon your initial level, but it's difficult. And that's the problem in India for PCSK9. So what's your take on that? What should we do?
Yeah, well, yes. And every time I go to India, this is what people tell me. And the penetration of the PCSK9s is pretty minimal in most parts of India. Now, perhaps in Delhi, it's higher and in Mumbai, but what do I do? Well, in that situation, then I'm going to push the statin as much as the patient tolerates, add the ezetimibe, and I'm going to get it still as low as I can get it reasonably. We can only do what we can do. If the addition of a third agent is precluded by cost, at least I've done something in maximizing the LDL reduction that patient can financially afford and tolerate.
Okay, great. Now the STEP trial. So with this in today's practice, I mean, it's not easy to get an elderly man's blood pressure below 130. You really require multiple drugs. So now, what is the take for us as a clinician? I mean, would you be aggressive to go below 130 in all patients, in elderlies? And what do you do in your practice? And how aggressive do you be in the number of drugs you use?
Well, now that's a great question, because if the patient has resistant hypertension in terms of, let's say they've been on Coumadin for 15 or 20 years because of atrial fibrillation, and now they have diffuse medial calcinosis, and their blood pressure is really difficult to control. I'm not going to add 5 medications just for their blood pressure. But I will investigate what else I can do. I may look at their renal arteries. I'm certainly going to do a complete inventory of what drugs they're on and whether or not those drugs are really most appropriate for that person. Because we know that we need to economize as much as possible, and we need to optimize interventions that are most appropriate for that person sitting in front of you. So I definitely personalize it. But if it takes 3 drugs and I can safely reduce the blood pressure, and let's face it, so many of these drugs are now generic. They're not that expensive. And the average person, I'm not saying everyone, the average person can afford them. And I will push those drugs and try to get that blood pressure under 130 as much as possible. But if the patient doesn't tolerate it, if there's a tolerability issue, or the blood vessels are just too damaged and they're not going to tolerate 5 drugs, we have to call the ball somewhere and just say, okay, I can get it to 140 or 145, not safely below that, then we stay there. Just like with the diabetic. If you have an insulin dependent diabetic, and the best they can do is an A1C of 8.2, because if you push the insulin too much, they get hypoglycemic. It's not safe. So we have to be reasonable as well.
Final question on diabetics. Say for a clinician today, should the protocol of anti-diabetic drugs change? Suppose somebody has a stent and ASCVD evidence. So SGLT2 and GLP-1, I mean, shouldn't they be the first that we should start besides metformin? Or in India, we still have all the other anti-diabetics written, and then we come to SGLT2 and GLP-4. Of course, GLP-1 we know because of the cost. But in your protocol of anti-diabetic therapy, I mean, now, shouldn't we change the protocols of anti-diabetic drugs?
We should. Why? Because although metformin is cheap, it's effective, it has no cardiovascular outcomes. If I came into your office tomorrow and I said, Dr. Sati, metformin in a subgroup analysis of 300 patients from the United Kingdom prospective diabetes study, in a post hoc study of 300 patients who took metformin, there was a modest 32% reduction in MI, but nothing else. And the p-value was 0.049. Would that just knock you over? No, it would not. And I think that data and various meta-analyses that have been looked at really do not provide a convincing view that metformin is as beneficial as we historically have viewed. Now, it's a wonderful hepatic insulin sensitizer. It's a great drug if you tolerate it. But in terms of prioritizing pharmacologic interventions, when you look at these extraordinary endpoint reductions with empagliflozin and canagliflozin and others in heart failure and their impact on mortality, it's amazing. And then if you look at the GLP-1s in patients with ASCVD, again, very impressive. LEADER was the first diabetes clinical intervention trial to ever show a reduction in both cardiovascular and all-cause mortality. And it did so very rapidly. So yes, I think GLP-1s and the SGLT2s, as appropriate, should be moved first line because, you're asking me, a lot of these diabetic patients, they're on lots of drugs, 7, 8, 9, 10, 11 drugs. Wouldn't it be good to prioritize this a little better so that we're using drugs that we know work and profoundly impact risk? We use them first. And then if we need adjuvant therapy, we go down the list of what works best after that.
Great. I think we're at the end of our time. The last question is, just to be honest, and what is the impact of all these, data, and you have ESC guidelines and ACC guidelines. Every year we keep on discussing them, and it's great to discuss. What do you think is the real impact of all this data and knowledge in changing clinical practice? I mean, a true opinion overboard. And do really people change clinical practices?
Not nearly often enough. The European guidelines are remarkable because now they're being revised on a virtually annual basis in terms of lipids and cardiovascular disease. And John told us that they're going to be changing heart failure guidelines every 2 years. So they are really keeping up with the pace of the publication of clinical trials and their interpretation. So that's great. But I would have to say that the vast majority of physicians in the world are not keeping pace with this. They are not reading and practicing according to the guidelines. Let's take the example of LDL alone. If you consider the studies that have looked at just getting to an LDL of less than 70 among very high-risk patients, never mind 55, never mind 40, 70. That happens 18 to 40% of the time, depending upon which study you look at where in the world. Similarly, for A1C of less than 7, that typically occurs around 15 to 45% of the time. Blood pressure, similar. Okay, so there's a long way to go in just simply controlling. We know that if you stop smoking, you get the LDL, the blood pressure, the A1C down, you profoundly impact risk for micro and macrovascular events. But it just doesn't happen. And we need to help each other do this because we are leaving so much risk on the table when we suboptimally treat. So much risk that in the year 2021, we can profoundly impact.
Thank
And
you.
you
Thank
know, I spoke at your hospital in Pune 6 years ago, and you chaired that session. I remember you.
Okay, great. Thank you, Dr. Cho. I think that was great insight into various clinical issues. I think we can go on talking, but we have to stop somewhere. So, Saurav, I think time is up. So, over to you. Indrajit?
Yeah, so thank you very much for giving me the opportunity. I think it was a wonderful session, although there are some technical issues, but no, it was a wonderful session, great discussion. I thank all of the audience who have listened to our this program, and they have posted their questions also in the chat box. Definitely, this has been addressed through our eminent panel and also by our chairperson, Dr. Sunil Sate. So at the outset, finally, I thank Dr. Balbi Singh, Dr. Sunil Sate, Professor Peter Todd, and also Professor McMurray for this wonderful session. And thank you very much once again for the same. Thank you.
Thank you.
All
Okay,
the best.
bye-bye.
Stay safe, healthy. Thank
Thank
you.
you. Thank you.